Erica, super. Okay, welcome, ladies and gentlemen, to the November board of the Wye Valley Trust. We continue to live in extremely strange times with the COVID pandemic, so the board is continuing to meet digitally, but we hope through YouTube Live you find access to the board meetings helpful nonetheless. So we will move on then to the normal business of the board. I don't think we have any apologies for absence. Any new declarations of interest? Please come off mute if you have any new declarations of interest.
Russell?
Richard?
Yeah, yes, I have a new interest to declare. I've recently been elected as a trustee of the Association of Directors of Adult Social Services, and I'm optimistic it won't be a conflict of interest.
Okay, I'm sure it won't be either, Richard, but congratulations. It's great to have you as a non-executive, given your experience in that field. Any other new declarations of interest? Okay, so we move then on to the minutes of the meeting held on the 1st of October. Is everyone happy with the accuracy of those minutes? Please come off mute if you weren't. Okay, I'll take that as acceptance and approval of the minutes, and I will duly sign them in due course. If we then go to page 16 of the admin control pack, we have the matters arising. And the first was a COVID update, and we'll come back to that later, and that's included within the activity report regarding routine specialities. On the Chief Executive's report, we had the issue of ensuring members of the public are aware of updates regarding COVID in the county. Glenn, that was handled through the Director of Public Health briefing on the 23rd of October to raise public awarenesses on the results of good compliance, but clearly we're in our second national lockdown at the moment, so the rules have somewhat changed. On the workforce report, we requested that future workforce reports included more details around why staff are leaving. Jeffrey will come back to that later as it's included, thank you. Then on the digital program update, Glenn to provide an update on the digital hub. That was partly covered in a foundation group board meeting on the 3rd of October and is due for a group-wide launch event in November. But the exciting thing for us at Wye Valley, being part of the foundation group, is some really exciting technical and digital innovations being trialled in that hub in Stratford-upon-Avon, which will allow us to roll out at pace across Wye Valley, South Warwickshire and the George Eliot, technical innovations to help improve patient outcomes. Then our future policy panel reports will include a link to the policies. That's been done. Thank you, Erica. And then on financial performance, Howard will review how typical the substantive medical staff additional payments are and compare these to other trusts. Howard?
Yeah, apologies. This sort of, I think, got overtaken by events. I have spoken to David Moon about it on a couple of occasions, and I'm talking to him again tomorrow. He sort of was happy to try and bring that to a conclusion shortly. So yeah, it's so taking a long time.
Okay, well, we'll leave it as a carried forward item, Howard, but if you can polish it off or get Dave to polish it off by next month, that would be great. And then finally, the digital program update comes back in December. So looking forward to that. There's been a lot of work going on this week with our clinical colleagues reviewing the different EPR options we have going forward. Are there any matters arising that I've missed? Okay, thank you. So Glenn, over to you for the Chief Executive's report, please.
Thank you, Russell. And I start with a very sad item, actually, as my first item in my report, which is Howard announcing his retirement in the early part of next year, which is a very sad day. As I say in the report, he's much more than just a finance director, really key member of the team, and has lived the Wye Valley journey with us over the last few years. Absolute gentlemen, say here. Actually, the thing I was thinking earlier, actually, it will reduce the attendance at our public AGMs, because you always had a bit of a gathering of fans that used to turn up to those AGMs. I'll then move on to...
They were called the Oddies.
The CQC review of provider collaboration during COVID, which Jane and I and a number of other colleagues took part in. We will get a summary of those findings soon. Just by way of a note, we had a really good session this morning at Board Workshop about the progress that's been made following our previous CQC inspection and the recommendations made. So we will be in communication with the CQC about where we are with those developments soon. The testing update there, obviously been overtaken a little bit by events over the last week. So I refer here to the LAMP technology and also lateral flow technologies being used. So this is significantly increasing the testing capability of the NHS, and as demonstrated this week, where we've started testing an entire population in Liverpool, we will also soon be testing all NHS staff routinely. But at the moment, that is concentrated on the tier 3 areas, and also concentrated where there are localized outbreaks as advised by Public Health England. But the capacity is increasing all the time, which is good. The NHS has actually met its initial milestone to have 500,000 tests per day capacity by the start of this month. And then I refer to rapid testing, which is something we really do need for this winter. And there's a deployment plan for that, which will ensure that we have that capacity available this month, which will help us to ensure that all the non-elective admissions are tested quickly at the front door. Then there's an update on Starboard, which I won't dwell on. NHS providers state of the sector survey. The thing I pull out from that is the 99% of trust leaders being concerned about the level of burnout amongst the workforce. Don't know what that 1% was thinking, but they probably burnt out themselves, because I think we all worry about this, and it's something throughout the course of the meeting and over this winter we just need to make sure we give some attention to making sure that our staff are feeling supported and that we're keeping an eye on those things. System funding envelopes, Howard will talk about this a little bit later. The overall STP position is 14.6 million variance from the required break-even position. There's a strange set of circumstances around NHS finances this year. So additional COVID funding is being put into systems at STP level. We've had a share of that, but our share of that 14.6 million adverse position is a 7.37 million position. So it's really important that we try to manage that. All of this modelling has been based on R equals 1. So the levels of demand across the NHS at the moment will obviously have an impact on the cost of running those services over the winter, but we do need to ensure that we effectively manage our resources within that. And then finally, I refer to NHS Fab Change Day, which a lot of activity across the group promoting some of the innovation that's been put in place. Ali Bolton took part in a global virtual conference. But also what I'm going to do from now on is include each month a section about something that's going on that we ought to be celebrating. And what I've chosen this time is the Community Integrated Response Hub, which is a fantastic innovation, and it helps to demonstrate, I suppose, part of what we've been able to do by concentrating on out of hospital to ensure that patients who need hospital have access to it, but ideally if they don't, we can deliver care and services in the community and also speed up discharges from hospital. And there's an infographic of that on the back page, and it further goes on to demonstrate the increases in workforce capacity that we've been able to put in place. So that will certainly help us over what will be an interesting winter. That's all I wanted to say, Chairman.
Thank you very much, Glenn. And then we will come back to this, but Howard, you've been an extraordinary servant for the Trust, and you will be immensely missed. But we will come back and celebrate again your tenure at another time. So any questions or perspectives to Glenn, please come off mute.
Yeah,
Andrew?
yeah. Just on the Howard thing, I just did wish that that we could be able to use the local hospitality services when he does leave. It'd be important we can thank him in person. But a more serious question, just picking up on Glenn's report and the survey of the NHS providers, and I just wondered to what extent we're reflecting on the sense that the leadership challenge in this time round is different to the one that we had last time round.
Yeah, I mean, there's obviously a number of things that we have more certainty around this time, certainly in terms of how we manage COVID and the supply chain issues around PPE. So that there's a better feeling of readiness this time. But I think that the challenge for us is that this obviously comes after a long year for NHS staff of managing COVID, and so the fatigue that our workforce are going to face is probably one of the things that we probably need to concentrate on more than anything else, because as I say, we generally are better at managing COVID from a clinical perspective. But then I suppose you also have to factor in we haven't closed down elective operating across the NHS like we did last time. So electives going on. Winter is upon us. So and then we have the other factor of the transition period of Brexit as well, just to add to the mix. So and that could bring some supply chain concerns as well. So the leaders around this meeting are obviously focused on that, but at all levels in the organisation, it's been great to see the kind of readiness and the positivity. We saw it this morning, didn't we, with the maternity team, where they actually were quite excited by some of the challenges around COVID, because it allowed them to innovate and look after their patients in the best way possible. And I saw an example this week of feedback from a staff member about the support they've received from the exec team, which I haven't shared with those exec team members yet, because I'm just seeking the individual's permission. But lovely to see that they reached out for a bit of support and got it in spades from the exec team. So it's about supporting our staff. As I say, we're much better placed in terms of managing COVID, but then we have the complexities of winter demand alongside it. So it will be a challenging winter.
Okay, just keeping things going. Richard?
Yes, thank you. Howard, I will greatly miss the opportunity I've had in previous meetings to wind you up at the end of particularly difficult finance reports by asking you if you prefer a carriage clock or John Lewis vouchers. But now we can ask you the question for real, can't we? But on a serious note, the point about staff wellbeing, Glenn, and I'm sure you've all got this covered, but just to be absolutely sure, we are doing everything we can to support and sustain our staff in the difficult months ahead. And a specific point for executive director colleagues, if there is anything we can do or not do as non-execs that is going to make your life easier over the next few months, please tell us, because we are a unitary board and we need to be supporting each other. Thank you.
Absolutely. Thank you, Richard.
I won't ask Howard to answer that straight away.
Yeah.
Those questions at the end of his reports will probably be the first request that you could not do. So I mean, I think we're well placed. There's been some really good work. Jeffrey's reported on some of that at our previous board meetings. There's also some national offers that have been ramped up over winter and some regional support for staff. But we can't be complacent on this. We need to keep looking and checking and making sure that our staff are feeling supported.
Okay, team, we'll move on then. But can I ask colleagues to use the digital hands if they want to ask questions? It just makes my life a little bit easier. Thank you. So, Jane, the integrated performance report, please.
I've stolen most of my thunder and the things that I was going to talk about, because in a way, I think I can almost do my introduction with a single word, which is pressure. There's a huge amount of pressure. Some of the things that Glenn's talked about in terms of winter and COVID and doing elective care, but on top of that, we've got a huge amount of building works going on across the site, and but also a huge amount of delivery as well, which is really encouraging. I think the other thing that's encouraging is our workforce metrics have stayed really very positive, and we're all really committed to making sure that we continue to concentrate on that. I met with a group of consultants earlier this week, and one of them said and asked them sort of how's everyone feeling about going into winter, and the answer was it's doing it all over again but without the adrenaline. And I think that probably summarised how people are feeling. It's without that level of it's new, there's lots of adrenaline, lots of new things that we know what's coming, and people are sort of girding their loins rather. So I think the Health and Wellbeing Week, which was run a few weeks ago, the Black History Month across October, all of those things I think have been really timely to tell the workforce that we are their health and well-being is really important. And so for us, I think keeping those lines of communication, those channels open, so that we continue to listen and respond to what staff are saying to us. And I can certainly assure you, as a leadership team, that's absolutely in the forefront of our mind. I guess the only other thing I wanted to mention was looking at just that sort of portent of things in the future, and we've seen a bit of a glimmer of that. I think, well, we've talked before about what it might be like to be lead provider and start thinking about working in a world of a capitated contract. So as part of, and Glenn mentioned it earlier, that work that we've done around the community integrated response hub, and increasing our resources in the community so that we can both support patients better at home, and so not have to come to hospital, but also to support that discharge better as well. And our conversation with the commissioners this time has been very different. Instead of here's the pathway, here's the money, handing over to us, it's been a conversation about this is the resource envelope we've got, but actually as a partnership of providers across ourselves, primary care, local authority, the conversation's been, what do you think is the best way to invest this resource? And that's broadly what we've done. We'll spend a bit more time next month in our workshop on the context of all of that and the sort of things that are being invested in. But I think it's been a really positive move, and I think it sees that maturity, I think, of our system.
Thank you very much, Jane. Any questions or perspectives to Jane, or do we want to get into the detail?
Chair?
Yep.
I'm not sure how to use the digital hand. Anyway,
okay.
I just wonder whether it's a good moment to pick up the agency issue. And the reason I say now is it's mentioned in Lucy's report, in Jeffrey's report, and in Howard's report. And there's a sense actually that what's driving it is John's report, because we're doing more. So it dipped in April, May, June time. The trend is upwards. It's part of our financial plan, and I just wondered whether it's worth picking up now. Really.
Okay. Thank you, Andrew. So, Jane, what's your view on what's happening on agency, and what can we do about it?
Yeah, I think Andrew's absolutely right. It's connected to doing more activity, and saying we haven't dropped all of those extra things that we're doing around COVID in terms of swabbing teams and front door teams. They're all extra things that we're doing now that we didn't do in the past. I think that's exactly what it's related to. It's certainly not higher turnover of staff. I'm going to say that those metrics still look very good for us. We are doing more international recruitment, and we will see some more nurses coming towards the end of the year to us. It was primarily around the new ward block, but so those are in the pipeline, and we're still recruiting pretty strongly into consultant posts as well. David and I have got a couple of interviews coming up. But I think your analysis is absolutely right, Andrew.
Okay, thank you, Jane. Colleagues, therefore, happy to move on to quality. So, Lucy, over to you, please.
Certainly, thank you very much. I just wanted to start, Glenn's already alluded to it, but firstly, primarily talking about the surgical division, who spent an hour with us this morning talking about the massive improvements that they've made following the CQC inspection last year. And I certainly can't, in the time I've got now, do any justice to the presentation they delivered this morning. but just to say they have made huge strides in relation to governance and safety within that division by strengthening leadership, revising their governance and divisional structure, and engaging with staff and supporting and developing and training staff to do the right thing. So that was my first point. Secondly, I just want to talk about our learning disability service, which I think is going from strength to strength. We were concerned during the beginning of the pandemic that perhaps learning disability patients weren't accessing our services. We'd seen a decline in the number of patients accessing our services and requiring support from that specialist team, but the numbers are back at pre-COVID levels. And it's great that we've had flagging on our electronic patient record system for the hospital for some time, but we've just in the last month had flagging within Symphony, which is our electronic patient record in the emergency department, which means now we can flag where we've got an individual who might need some adjustments made to their to meet their specific requirements and access the specialist team when required. The third point I want to talk about is just about visiting. So in August, we lifted our visiting restrictions in line with national guidance as the pandemic progressed. And regrettably, in the last month, we've had to make a decision to restrict visiting. So we have put some further restrictions in place, which means now that patients who've got a longer length of stay with us can still receive visits, but only up to 2 per week. Whereas that was daily previously. And it was a difficult decision to make because we recognise how important visiting is for our patients and also for families. But we had to take that decision in the context of increasing numbers, increasing incidence of COVID out in the community. We plan to keep our visiting as it is for now, but we do believe that the centre may well advise us to do something differently in light of the lockdown, and obviously we'll have to respond to that should that happen. Jane alluded to in her summary that we have had a couple of outbreaks on our wards, and although it's not included in my report, I'm pleased to report I requested a peer review, which is seen as good practice when you have an outbreak, and that took place last Thursday, so I'd already submitted my report at that point. But it is pleasing to know that that peer review, which was undertaken by an experienced infection prevention nurse provided by our commissioners, is that our personal protective equipment, how we use that, our mask etiquette, our infection prevention control standards, and our discipline around that, and our environmental cleanliness was as it should be. We certainly didn't have any shortfalls in terms of how we operate in our clinical areas. And there were some suggestions, some minor small suggestions around how we behave when we're outside of the clinical environment, which we will address. Flu. So we launched our flu campaign a few weeks ago, and the numbers as of today are that 1,900 of our staff have been vaccinated with the flu vaccine. So that's 56% of all of our staff and 57% of our frontline staff have been vaccinated so far. In the first 5 days of the flu vaccination programme, we'd done really well, and we've lost a bit of traction behind that because we had to wait for another vaccine delivery, which we didn't receive until last Friday. It's more important than ever that our staff have the flu vaccination in order to protect our patients and their families. And it's more important than ever because we have seen a couple of flu cases come through our front doors. They haven't required admission thus far, but as Jane said, winter is upon us. And then just to touch on the point that Andrew made as my final point, I was going to talk about the increasing reliance on agency and temporary workforce. And it is absolutely being driven by the different ways that we're having to work in response to COVID and sort of the rearrangements of our wards. Which is driving that. Other than that, I'm happy to take any questions.
Great, thank you very much, Lucy. Very comprehensive. Can you please raise a digital hand if you want to ask a question to Lucy? Okay, Lucia, just going back to what we've talked about before, please pass on our thanks to all your teams for their hard work and for the hard work that's about to come. It's greatly appreciated. We'll move on then to activity. John.
Thank you. Just want to take you quickly through my report and some of these sort of more notable issues, although they all deserve some time perhaps. Excuse me. Cancer referrals have returned to around 90% of their pre-COVID numbers, and that's fairly consistent across the West Midlands, I think the country as well, sort of around about that level. There are some exceptions, I think we point them out there around urology and a national campaign to try and get something to come forward. Performance against 2-week standard is very strong at the moment. The trust we're doing really well, 97.5% and 100% for breast symptomatic. So that's positive. Cancer, the 28-day faster diagnosis work it continues. We've slipped below the line at the moment. We've been up there previously. We'll get back to there. Endoscopy will help resolve that when we get the numbers up in endoscopy. Cancer 62-day has been a little bit more positive the last couple of months, and certainly I think that the benchmarking against peers gives me some assurance that we are delivering at least in line with our peers. It may dip a little bit next month, but we'll get back to where we are now shortly afterwards. There's quite a bit of detail around referrals. I think that you asked for last month when I was away. I think the month previous, to be fair. So we supplied that. I'm not sure how helpful that is, but it does show the sort of the variation in terms of specialty and urgency of referral in terms of where that is. It's hard to know what we can do to influence that directly, other than continue to take part in local and national campaigns to encourage the public to come forward, etc. We are closer to our own plans, our own expectations, which were driven by our clinical team. So as we constructed our restoration plan, we asked our teams what they thought would happen, and they constructed a sort of a return of activity profile over time, per specialty, per urgency. And we are a lot closer in terms of what our expectation was around that and what's happening. I mean, it's just worth noting perhaps that the volumes that we're over on 2 weeks against our plan, but we're under on urgents are very similar. So the more urgent patients are about what we expected. They're just coming slightly different referral types. Go through that. Referral to treatment. We continue to improve for English patients and holding our position against Welsh. That doesn't mean there's an awful lot of patients being waiting a long time, which is shown in the 52 weeks, which continues to climb. We had anticipated that would have started to slow down by now, and perhaps even would have flattened off. So, and this is the volume of urgent work coming through is slowing us down, but we'll continue to work on that. Diagnostic waiters over 6 weeks is coming down, and actually the breakdown by modality I think is quite useful. There's an awful lot of patients within the echo. There's some detail there which I won't go through now, really highlighting what each team are doing to recover their position, and they are all making progress, particularly within the imaging modalities. Some good news, I don't know if it's shared with you previously, we have just secured funding for a third CT. So we've already replaced, we've got a brand new CT in place. The second original CT is being replaced and will be available around Christmas, but a third CT will be available in the first few months of the new year, which will be in a pod attached to the building, which has been funded externally. So that's fantastic news. It'll allow us to move that quite quickly going forward. Endoscopy continues to be a concern in terms of volumes. We haven't achieved our own plan yet, and certainly not the national ask. We are working with the CCG on some options in terms of increasing productivity and capacity. We will get a significant boost during this month as urology move their cystoscopy service into their urology service and out of endoscopy, which releases 2.5 sessions. So there will be a step change this month, which is good, but I think there's some more work to do with the team, and I'm working with them now on a small case for CCG to consider about how we might do more quickly. In terms of ED, very similar story to the last few months in terms of activity. It's near previous levels in terms of ambulances, attendances and conveyances. The one thing I would note that you can't see on this report is the volatility of the numbers. So the variation day to day is really quite exceptional, something you're not used to seeing. I've been doing this for not this, but I job in the NHS for 34 years, and I've never seen the variation in demand from day to day. So we can have 200 attendances one day and 125 the next, 70 ambulances and 40, which is really quite remarkable and very difficult to manage. in terms of what that does to the way the teams think and work and react. So that really is quite an interesting phenomenon that's sort of very COVID specific. Performance isn't where we want it to be. We are working with the teams to try and improve performance. They are doing a huge amount of work, which they've identified in this report. There are some real highlights though. 38% against the same day emergency care is fantastic. That's come up really. I think it was 24% 2 years ago. So 38% of patients presenting have been admitted, treated, and discharged on the same day. Their ambition is to get over to 45%. We are subject to approval by the board, and all things being equal, we are looking to extend the department both in terms of ED and creating a dedicated same-day emergency care unit, which we would hope we would be able to start work if all things go well by the end of November. That will allow a very significant change to the way we manage patients on the same day, including our relationship with primary care and community care and the way patients are managed in a much more integrated way. It really is quite exciting, to be honest. And then just finally, bed occupancy is again, it's our abilities to flex capacity within our bed stock is significantly diminished due to COVID restrictions and the use of alternate areas, and does create a real issue with flow from time to time. And we've had some difficult days over the last few weeks. We're in a much better position today, have some great amount of work, and to say some of that change in fortunes around the volumes of patients attending. So I think that's probably all I want to say. There's one final thing, which is shameless pushing my own agenda forward. If you've not joined the Transformation Tuesday, which is every alternate Tuesday at 9 AM via Teams, can you please do so? You've asked what you could do for us. The teams and the people that are doing some stuff. Last Tuesday was inspirational. It was an exceptional example of teams working together. Nearly every conversation was about the way we delivered integrated care, patient focused. It wasn't about organisations. It wasn't about specialties. It was real patient focused, integrated sort of conversation. There was 40 of us on the call. It should have been more. It needs to be more. I'd like to see some of you there if you've got the time. We never take longer than an hour. It's very, very lively discussion, but an awful lot of enthusiasm. So I'd like to finish on a high for once and encourage you to join us.
That's great, John. And can you make sure we, because I don't get the invitations to that, can you make sure I get the invitation to that to my personal email address? Questions or perspectives to John?
Chair?
Andrew?
I'm trying to work out the digital hand. It'd be good to have I don't know if the invite for the teams comes out. That would be worthwhile. If we have the invite, we're more likely to join in. But two issues really. One is the diagnostics, which you've mentioned, and the other is one which I picked up in the performance data, emergency readmissions, which seem to be on the rise. I suppose both of them potentially have an impact on the bed occupancy, the flow, just whether there's an issue there from those two.
John?
I hadn't noticed the emergency readmissions at this point, so I'll have to have a look at that and find out what that is, and whether that's something to worry about or not. So I'm happy to come back to you offline or next board, whichever feels more appropriate.
Okay, if we just minute it, John, and come back, that would be great. Thank you, Andrew. Anything else for John? Okay, thank you very much, John. So we then move on to workforce. Jeff.
Well, thanks, Russell. Well, I guess our health and well-being remains a top priority from a workforce perspective. So we had a very successful health and well-being week in October, and we're going to build on that. So working with internal and external partners, we had a plan of events which we're going to roll out this October, December before lockdown came in. However, we're going to do virtual stuff, and then we can rebuild on that once the lockdown is out of the equation. So certainly health and well-being remains a top priority for myself and colleagues within the organization. As Jane mentioned, October was Black History Month. So we supported Black History Month within the organization. And one of the key highlights was the Show Racism the Red Card campaign, which we did on the 16th of October. So you had lots of people in red, and they went down really well within the organization. We also ran some inspirational stories. We had contributions from the chairman, the CEO, the MD, and those inspirational stories went down really well within the organization. And we're going to build on that as part of our EDI agenda for the organization. In terms of the HR KPIs, we carry on making good progress with a lot of the key performance indicators. Recruitment and retention obviously is one of the other key areas for the organization. So what I'll do for the next board meeting, we'll do a deep dive report into recruitment and retention. So we've developed a comprehensive plan, but I'll do a deep dive next time so we can see the actions that we have in place to address recruitment and retention issues within the organization. Those are the key highlights I wanted to portray. So happy to take any questions.
Great, thank you, Jeffrey, and really great that Black History Month was enthusiastically received in the organisation. Any questions or perspectives to Jeffrey? Okay, super, thank you. As members of the public will be able to tell, Jeffrey is setting the standard for sartorial elegance at the board meeting. So I expect the male members of the board to raise their standards next month. So we'll move then on to finance. Howard, who used to be the sartorial leader at the board. Howard, how's the money looking?
I'm not quite sure how to respond to that earlier comment. No, in terms of the money, I guess I'm going to spend more time on looking at the plan for the second half of the year rather than what happened in the period to September. But briefly, September was the last month that we had the retrospective top-up. And that is the central allocation to get us back to break even. I did think it was worth noting that in September, we actually had a top up of 1.4 million, which was the highest sum in the 6 months. Indeed, it was almost half of our total retrospective top up for the first 6 months. And the importance of that is I think it was an indication of the growing increasing costs that we have been experiencing, and I guess more of that when we come to the plan. And I think that the main costs have been partly to do with the cost of putting on additional work, and also the issue which has already been mentioned on a couple of occasions, increasing costs of agency, which we're keeping a close eye on. And you will have noticed from the report that although it was an old agency cap, September was the first time since April that we actually exceeded the agency cap. So it may all be work related, or it is all work related, but it's definitely on the up. In terms of capital, we've so far spent almost 12.5 million at the half year out of the 38 million. A long way to go, but obviously the key element of the expenditure is going to be in relation to the new wards. But to finish on two positive notes, we've still got a very healthy cash position, which is pleasing. And you may also have noticed that for the first time in a long time, the overall balance sheet is actually in a positive position, thanks to the transfer of loans into PDC. So happy to take any questions on any aspect of the finance report.
Thank you very much. Questions or perspectives to Howard? So as we speak now, Howard, I know what the number was at the month end. How much cash have we got in the bank?
About 30 million.
Okay, thank you. Okie dokie. Colleagues, happy to move on to the items for approval. The first of which are a series of safeguarding annual reports. Lucy, do you want to handle these collectively?
Yes, please. And I think Eric is going to put the presentation up for us, if that's possible. But I will take them all collectively. So I have the absolute pleasure of managing 3 small teams that take responsibility for looked after children, adults who need to be safeguarded, and then the child safeguarding team. So I have the pleasure of managing them, and I really do think we have a lot to be proud of in relation to the work that they do working with vulnerable adults and children. So overall, it's great to note that the annual reports give assurance that we're meeting our statutory responsibilities across all three teams. We've always had great engagement with partner agencies for the 4.5 years that I've been working at Wye Valley in relation to safeguarding. But goodness me, has COVID changed that? And we've got really, really good engagement in terms of working in different ways to continue to support those vulnerable individuals. Despite COVID, we've managed to maintain full attendance at the meeting infrastructure that supports all of this, so the partnership meetings, the Safeguarding Adults boards, the associated subgroups, and any of the oversight groups that work in this domain. We've managed to maintain a strong position in relation to training compliance across all three elements. And I think the teams are to be commended for adapting and changing and in terms of working differently during COVID. Can I have the next slide, please, Erica? So just taking each of the reports in turn. I'm just waiting to see, have we got technical difficulties, Erica? Ah, perfect. So just a quick canter through adult safeguarding first. Certainly in the last year, what we've managed to do is build a much more resilient team. So we used to have a Wye Valley Trust employed learning disability part-time nurse. We now deliver the learning disability service through a service level agreement with our local mental health trust. And as you heard earlier in my quality report, that team's going from strength to strength in terms of supporting individuals with a learning disability. We've had an independent domestic violence advisor, an IDVA, who's working with us. They're in their second year with us now, and working very closely with maternity and the emergency department in terms of supporting individuals who are victims of domestic abuse. During the last year, we've appointed a dual qualified advanced practitioner. So she's a registered general nurse and also a registered mental health nurse as an addition to the team. And that was recognising that we had a gap really in relation to our understanding, education and training in relation to the application of the Mental Health Act and the Mental Capacity Act. During the last year, we've successfully implemented our mental health policy and working with our local mental health trust, who are working with honorary contracts to provide sectioning arrangements where appropriate to individuals who require the Act to be applied. The liberty protection safeguards have been deferred. They were due to come into being in 2021. That's been deferred till 2022. And we still await the code of practice, which has not yet been released for comment, but we'll start to, when we do receive that, we'll start to show us what the implications are for us in terms of taking over our responsibilities in relation to the liberty protection safeguards. And one of the challenges in relation to adult safeguarding is just our staff across all disciplines, doctors and nurses, in terms of the application of the Mental Capacity Act, particularly around assessing individuals' capacity to make decisions and then acting in their best interests. And we've got some specific training for the nursing workforce and the registered, the advanced practitioners working with the medical director to deliver training to our consultant colleagues. Next slide, please, Erica. So in relation to child safeguarding, during the last year, we had a multi-agency health role move from the commissioners into Wye Valley Trust and into the Safeguarding Children team. That role supports and provides health advice to the multi-agency safeguarding hub, the MASH hub. We had previously had concerns around, so the named midwife role sat within maternity services and often didn't have sufficient capacity to pay attention to safeguarding because of other competing operational demands within that service. And we've just recently appointed to a named midwife role that's now sitting in the safeguarding team, which provides greater resilience and obviously enables the capacity that's required to fulfil the requirements of that role. And we've also recently fully recruited into the team. So we're now fully recruited and have filled our last specialist advisor vacancy. Many health visitors and school nurses were redeployed during the first phase of COVID into alternative roles, just leaving a very small core team to work with small children and vulnerable families. That won't happen in phase 2. There's been a very clear direction from the centre that school nurses and health visitors must remain in their current roles to support families going forward. We have seen a huge increase in domestic abuse numbers during the last few months. We don't have a domestic abuse lead, but we do have a health visitor who leads on domestic abuse within the health visiting service 2 days a week. During COVID, she's been released to us nearly full time and has been supporting the multi-agency domestic abuse hub that was developed during COVID. Which meets on a daily basis to look at referrals and provide support to vulnerable families. And the hubs work so well that the intention is across our healthcare system that will become a business as usual model. We had previously had concerns around the number of children on child protection plans and were worried that perhaps referrals weren't being made or thresholds weren't being applied correctly. But certainly in the last quarter, we've seen the number of children on child protection plans being at a level that you would expect for our population size. And we're awaiting the publication of the domestic abuse bill, and we haven't seen the detail of that yet, so we don't know what that might mean for us in health or our strategic partners. So that bill is awaited. And the final slide, please, Erica. And then finally onto the child in care. So we've always in Herefordshire, the number of looked after children in Herefordshire is much higher than the national average, and that's certainly continued during 2019-20. And certainly in the last quarter, actually, what we're also seeing is a number of our children, an increasing number of our children being placed out of county. During the last year, we've had difficulties in recruiting a community paediatrician, and we were successful in recruiting an additional community paediatrician in the last 6 months. We were hopeful that the recruitment of that would mean that we were able to meet our initial health assessments within the statutory timescales, but unfortunately that has not been the case. So there is actually a meeting happening today with the community paediatricians and the management team to look at that and see what can be done. And we've just had some news hot off the press that there may well be some mutual aid available to us from partner trusts to support that. So I can update on that in the future. In the previous annual report, we did report that the looked after children team of nurses was significantly under-resourced in relation to the number of children that are looked after within Herefordshire, and we were able to increase the nursing establishment by a further 2 nurses in the last 12 months. I take my hat off to the team in terms of their use of technology during COVID. The children absolutely love it. We've gone 100% virtual, and we've achieved 87% compliance with review health assessments within the statutory timeframes through the use of virtual assessments. So excellent work on their part there. We've also introduced new review health assessment paperwork into our practice. Prior to COVID, we also had really good outcomes in terms of looked after children accessing dental care and immunisations in line with the national programme. However, the impact of COVID has meant that some of the immunisations were suspended, and indeed routine dental treatment was also stopped. However, all of our looked after children did know how to access emergency dental care should they require it. And finally, for me, we consider to deliver best practice in relation to the strengths and difficulties questionnaire. So this is a local authority responsibility, but our safeguarding team administer that because they view it's best practice, and it helps inform them where they need to focus on when they're doing their review health assessments. And as a consequence of COVID, what we have seen, particularly in boys, is a higher score in those strength and difficulty questionnaires. So boys struggling more than girls, and particularly during COVID and lockdown. That's whistle-stop tour to the 3 reports from me. And just on a final note to say, Quality Committee did have a much more detailed overview of those last week. And Quality Committee's view was that the reports were acceptable and to be recommended to board for onward submission to our partner agencies and to be published on our website if board are in agreement. Thank you. You're on mute, Russell.
That's kind, Lucy. We've had presentations from some of our safeguarding teams over the last 18 months, which are very assuring. And thank you for the assuring comprehensiveness of those presentations just now. Any questions on the 3 safeguarding reports?
Chris first.
Richard?
I think Chris was before me, so I'll allow Chris to go first as chair of the Quality Committee. I suspect she's going to make the same point as what I'm going to say.
Okay, Chris.
Well, that's very
please.
kind of you, Richard. Thank you. I absolutely right, Lucy. These reports have been presented to Quality Committee, and our assurance has continued despite the struggles that the team.
Chris, I can't hear you. We've lost audio with you. Could you try again, Chris?
Yes, sorry, Russell. Can you hear me now?
Yeah.
It's a bit Norman Collier. So if you try again,
so
that would be good.
I'll paraphrase just to say that the Quality Committee has received assurance on this work, and it continues year on year. And it's an area of work that's a bit unsung. And I did comment to Lucy and the teams, that they should be so proud of what they've done in difficult circumstances to ensure that these 3 groups of our communities are kept as safe as they possibly can. So it's a big thank you, and continue the good work. Thank you.
Thank you, Chris. And Richard?
I think Chris has said what I was going to say. So
Okay,
that's
fantastic.
great. Thank you, Chris. Yeah.
So I can't see any more raised hands. So are colleagues happy to approve the 3 safeguarding reports? Fantastic, thank you. So we then move on to the Quality Committee terms of reference. Lucy?
Yeah, thank you, Chair. This is just the annual review of the Quality Committee terms of reference. I didn't submit the track changes version because there are very few changes to the terms of reference, some minor changes to membership and job titles because of a restructure in my team earlier this year. The terms of reference continue to reflect the work of the committee. And I would just want to draw board's attention to section 10 of the terms of reference, just to check that board continue to be happy that they delegate the responsibility around staffing reviews and workforce safeguards to the Quality Committee rather than a function of the board.
Okay, great. So on that second point, first of all, is everyone continue to be happy to delegate that authority? Please come off mute if you're not. Okay, so that's covered, Lucy. And then the slide amendments to the terms of reference of the Quality Committee. Everyone happy to approve? Please come off mute if you're not. Okay, duly approved. Thank you. Just for future reference, when we do make changes to any of the terms of reference, it is actually helpful to highlight them. It just makes, otherwise we have to read all 6 pages. The Estates and Facilities Strategy. Alan?
Thanks, Russell. This is an interim 5-year estate strategy for the organisation, and it builds on a significant amount of engagement that we've done in the trust. And indeed, we spent some time looking at this as a board in the workshop last month. I think it's worth pointing out that the reason it's interim is it's no mean feat trying to design a 5-year strategy for your estate in the current circumstances. when we're dealing with so many issues all at the same time. And I think we all acknowledge that our plan may need to change over the coming years, and then we'll look at it at a later date and recast it accordingly. I'll take the report as read, but I'll just bring out a few issues within it. First of all, why is it important we have a strategy? It's very important. It tends to be a prerequisite of any major capital bids that we put in. One of the first things you have to demonstrate is that your organisation has both a strategy around its estates and facilities, and also has identified what its priorities are, and that's what this document does. Very clearly set out what the key priorities are around the organisation in terms of estates and facilities. And I think the other thing it is something that sets out the values of the trust when it comes to planning its estates and facilities, and the values are very clearly set out in the document. They're a slight amendment on ones from the previous strategy that we designed several years ago, very much about trying to improve the patient experience, providing a more therapeutic environment for people to receive care in, to improve our efficiency and support the business of the trust, to increase the capacity of the organisation to deal with the demand it faces, and finally to improve its sustainability. We agreed the sustainability strategy earlier in the year, and your estate is a key way of delivering against that. Some of the specific items that I would address in here that are sort of higher priority and that we're grappling with at the moment. Well, obviously, there's all the work that we're doing on site at the moment. But this strategy looks beyond the current phase that we're in to the future, and identifying those schemes that we start to need to address in the coming years. One of the things I'd highlight immediately is theatres, and in the capacity plans that I brought to the trust in the past, theatre capacity has been an issue for the organisation, and we're working through a business case for that at the moment. Endoscopy is also an area that is a risk for the organisation, both in terms of capacity and compliance, and we will be developing plans for that as well. I'll highlight that. There are also opportunities around the site, and one of the main opportunities, particularly on the county hospital side, is the space that will be created by the demolition of mono and leaden wards. The final hutted wards, when they go, will create quite a lot of space there, and that's really a development opportunity for the organisation in dealing with some of these issues. And the report sets out what sort of areas you could deal with that space. Endoscopy is potentially one of them. That's something that we will consider. I think the report doesn't set out a plan for that, but it sets out that's very much of strategic importance to the organisation. Being cast in the current times, the COVID looms large over this strategy, and in here there's a number of issues that we're having to deal with that have very much been brought to the forefront because of the current outbreak. A couple of things I would highlight there is outpatient facilities and what we do around outpatients, both on the county hospital site and what we might do to create outpatient capacity potentially at other facilities in the community, both in Hereford and Herefordshire. And secondly, our requirement for office space to keep people that do need to come to work and work from an office safe, and provide them with the space that they need to be able to do their job, then we're looking very closely at that. And the Lionel Green building, which is right behind me here at the moment, presents an opportunity to do that. It was part of our previous strategy. This document presents a way forward with that, which whereas we haven't been able to take the whole building forward as a project in the past might present a real opportunity, and we're actually progressing that at the moment.
Need to watch the time a bit, Alan.
Yeah, finally on that, I just wanted to talk a bit about the community. It's not all about the county hospital site, and there's an awful lot of work that we're doing, both from one public estate perspective from with our colleagues in mental health, primary care, and the local authority, but thinking about how community hospitals will adapt in the future. As we change the way that we provide care in the community. So that's alluded to in here as well. So finally from me on delivery, there's a section in here that gives us an indicative timescale, and this is more of a timescale in which we'll develop business cases. We are always reliant on seeking capital funding for these schemes, and so we'll develop business cases for all of these major schemes during this timescale. And really, I just wanted to highlight the capital requirement. So there's an indication in the strategy of the sort of magnitude of sort of cost in terms of capital that will require to deliver all of these schemes. Now, the usual caveats exist that capital isn't freely available to the trust. It would be required on producing business cases and bidding for money from via the STP or via NHSEI. So there's a caveat around that, but it just gives you an idea of the total value of the schemes and the timescales we look to deliver them in. And that's it from me. Happy to take any questions.
Thank you, Alan. Questions and perspectives to Alan?
If I may, Russell, the Stronger Towns Fund project is running at a pace now where £25 million is available to invest in the city. And I think it would be quite wrong that it doesn't recognise the interface with the health system. And Jane and Alan are very involved now in assessing, can't offer any promises, but assessing where the interface might benefit all parties. I've just been asked to chair the technical subgroup that will evaluate all the initiatives. And it's quite important that we watch for where that dovetails. Okay. I think there's another meeting in the diary next week, isn't there, Jane, Alan?
Okay. And thank you for facilitating that, Frank. I want to keep things moving, please, Alan. Andrew, did you have your hand up?
Yeah, just a quick question, really. The report on office accommodation refers to the requirements to meet COVID social distancing, but there's the opposite, isn't there? There's the more working at home, basically, and whether there's going to be a specific piece of work around the whole issue of working from home and what impact that has on accommodation.
Can I come back on that? Yeah, you're absolutely right, Andrew. And there's a piece of work that Howard's leading around that, that I'm working very closely with him and Jeffrey around that, looking closely at those teams that have been working from home for some time. And clearly there's a question about whether we formalise that into the future and what effect that has on our office space. We've been working that through. We've surveyed the management team in the organisation, so we've got an idea of what it looks like now and what it might look like in the long term, and we're working that through at the moment, and that's absolutely right.
Okay, and I can't see any other hands raised. Glenn?
I did put my digital hand up, Chairman.
I apologise.
So it's just emphasising the point that you've made, Alan, about PFI. So we're in last 9 years of the contract, and I know you and Jane and Howard are on this, but we were a first wave PFI, so this will be one of the first that comes out of the end of that contract, and it's really important, particularly bearing in mind our access to capital. It's really important that asset comes out in the condition it should, with no backlog maintenance. So we will need to manage that carefully.
Absolutely, Glenn. The PFI has been exceptionally expensive to the taxpayer, and it would be wholly unacceptable if we did not get the assets back in the condition we expected. Okay, so Alan, this needs, we understand it's interim. This needs approval from the board. We've been able to discuss it before. If you're not happy to approve, can we come off mute, please? Duly approved. So we'll move on then. Just a general point to executives, can we take the reports as read? Everyone reads the report, so just please pull out the highlights rather than all of the detail. All the Neds read all of the reports. So Howard, on the digital programme update report, what would you like to pull out?
I think I was just going to pull out a few of the successes to reiterate. Firstly, I think I've got to mention the fact that the electronic prescribing module, EPMA, actually went live in October, went live on Y Ward and has now been rolled into paediatrics, and has actually gone down really well as far as we're aware. It has been really positively embraced in those two places. Nurse noting also went live on Y Ward. We can't do any further in acute at the moment, but that's going to be rolled into community hospitals. The new electronic discharge summary module, which interfaces with EPMA, that went live in October. And we've also just concluded or completed the development and going live at the EMIS virtual ward, which is using the community module to help add to the number of options for us to try and avoid admissions. So 4 really positive steps forward. The one thing in the report which hasn't actually progressed quite so well is we were planning to switch off paper tests in pathology from the 1st of November, but that has just been delayed for a week or so due to final sign-off of processes. But on the whole, I think a positive month for the digital programme.
Thank you very much, Howard. Any questions or perspectives from colleagues? I can't see any raised digital or Chris?
I've raised. Thank you, Chair. We were hearing at Quality Committee the other day about the digital pathology system that's being introduced. I realise this is a network solution, but I think it'd be helpful if we could include it in these reports for completeness, because it had so many benefits that we were hearing about.
Absolutely, Chris. The actual business case is due to come to the Trust Board in December, and with an implementation in the first half of next year. So it would absolutely become part of the routine reporting.
Thank you.
Thank you, Chris. And any other comments from colleagues? Sounds like great progress, Howard. Thank you for your oversight of it. We'll then move on to the financial plan for the second half, which you sort of, Glenn and you're both sort of pre-led, but Howard?
Okay, so I'll take it as read, as stated, Russell, but perhaps I just wanted to bring out a few key issues. As colleagues will now be aware, the second half of the financial year is being treated differently from the first half of the year. The first half of the year, we got retrospective top-ups to help us break even. The second half of the year, there's been what's been called a financial envelope, which has been issued to STPs, which have then tried to agree a spending plan with trusts. And in a nutshell, trusts were expected to come up with a plan which continued to deliver break even. In our case, we've actually worked hard at actually reducing the costs within our plan, but we have still ended up with a deficit by the end of the financial year of £7 million. Now, on the positive side, this budget does deliver the restoration and recovery trajectory that's being asked for by NHSI. It actually takes account of the impact of investments which we as a trust either agreed before COVID or have actually taken in response to the pandemic. And we've had to make a number of assumptions about levels of activity and additional expenditure over the next 6 months. There's been a lot of pressure for us to get lower than 7 million, but actually, on my assessment, it is actually the best we can do given the other targets which we're trying to achieve. I do understand that nationally the gap between the financial envelopes and delivering break even is actually colossal, but certainly in our particular case, it's 7 million. I just wanted to highlight that that we have made some comparisons within the paper between 1920 and then between the two halves of 2021. I mean, they are incredibly different. It is quite difficult to compare because the last year compared to the first half of this year compared to the second half of this year, they are completely different. We have been experiencing quite different circumstances. But you will see, for example, year to year, our pay bill's gone up by 4%, and second half of the year to the first half of the year, our pay bill's gone up by 9.7%. And I think that does reflect the fact that we are having to do so much more additional activity in different circumstances in the second half of the year. So there are risks within it. Although we've mentioned in this particular meeting the concerns about the increasing agency, I just wanted to highlight that what we have done, although the budget for agency has been increased fairly to a fairly limited manner in this plan, we have fully funded the approved establishment. So if we do have vacancies in the establishment, well, then there is some funding that can go towards increased agency nursing. So although the increase in agency nursing budget does look small, it could be compensated. Other than that, I think my final point, actually, I just want to make one final point, and that is that in relation to COVID costs, we have, as Glenn said earlier in the meeting, we have been given an allocation for an assumed level of costs. This is supposed to exclude PPE, but we've already found, and the reason why it excludes PPE is because it's all supposed to be being provided centrally. We've already found that there are certain products which have been in short supply. We haven't been able to get them from the national system. We've had to go out and buy them ourselves at a cost of £60,000 for the latest consignment of masks, and that, of course, is the sort of pressure which we're having to bear. But I would like the board to take the view that actually we've worked hard to actually come up with a realistic budget, and regrettably, though, it does leave us with this £7 million deficit at the year end.
Okay. Thank you, Howard, for the briefing. And the key thing, I think, on the way the second half will actually look is what happens to COVID and the pandemic. That could blow out of the water all of the numbers. But on the basis of the assumptions of an R of 1 and Howard's description of the level of detail we've gone into, I've been involved at the ICS level with Jane on the ICS overall envelope. Any questions or perspectives to Howard? Okay, colleagues happy to approve? Please come off mute if you're not happy to approve.
Sorry, Russell,
sorry, Andrew.
Question.
Yeah, sorry, I thought I gave you the opportunity, but ask away.
I thought of it. You prompted me with the approval. I mean, what does it mean for us as a board approving the deficit budget at this stage? Actually,
Andrew, I apologise. This isn't for approval. It is for noting, isn't it, Howard?
To be totally honest, Russell, I had put it forward as approving, as a need for approval, because I was conscious, from my perspective, I'd been asked by the STP to come up with a balanced budget, and
that's fine, Howard. That's fine. But I think, Andrew, I think it's on what basis are we approving? We're approving on the basis of the assumptions Howard's told us about. I think the reality is, even if you take what, and Frank's noted this in the notes, given what the Chancellor's announced earlier, I think things are going to change. So I think we're approving on the basis of the assumptions Howard has briefed us on, albeit we now know those assumptions are almost certainly going to be broken.
If I could just add to that, Russell, as well, all three trusts in the group have had to submit plans which don't reconcile to the allocations given by by region, by national. And obviously there's a conversation going on with region on that at the moment, but we're not alone in this position.
So on that basis, colleagues all happy to approve, but obviously uncomfortable about the fact we know the assumptions are no longer valid. Okay, thank you very much, Howard. We'll then move on to and if we can pick up the pace a bit, guys, the quarterly mortality report. David?
Thanks, Russell. Essentially, it's a relatively good news story. I did raise my concerns in a previous report about the increase in the mortality statistics, but thought it was almost certainly due to our COVID experience. And I'm glad to report that the crude and adjusted figures have returned back to acceptable levels. We've seen improvements in our areas of greatest concern, so fractured neck of femur and congestive cardiac failure. Other bits of news, we've made good progress in converting professional fee payments for death certification to an electronic system, and thereby making it an accountable system for the first time. And it contains a description of the changes to the bereavement team, aligning it more to the national model. There's I thought a good example of Dr. Dykes' influence now in the community hospitals with her mortality newsletter based around the community hospitals. It contains the ongoing development of the perinatal mortality report, and just for a point of clarification there, we were reporting higher levels of the extended perinatal mortality than was actually the case, basically because we were over-reporting stillbirths. We used the definition of stillbirth was too wide, so we've now corrected that. It's essentially showing a position that's a little above the average. What I'm asking the team to do is actually give us a rolling 3-year mean so we can compare that with the national embrace mean. But I don't think there are major causes for concern, but that's an ongoing piece of work. And that's probably all I want to say, Russell.
Thank you very much, David. Questions or perspectives to David? Okay, duly noted. Thank you, David, and continue to keep us briefed. And then move on to the winter planning presentation. And John, I guess this is a challenge as well, given the developing situation, but what would you like to pull out?
Do you want me to talk in general terms or just go through the presentation very quickly? I'm doing about 6 minutes.
Well, we've read the presentation, so okay. I think just pull out the key points that you would want members of the public to absorb.
Okay, I suppose in terms of our planning assumptions, our expectation is that on average, with a background level of COVID R equals 1, we would have sufficient capacity. There would be pinch points throughout the winter like there are in any winter, but we would be able to cope like we do most winters and most of the time. We would get some easing of that pressure as the various schemes mature. So ITU coming back online helps because it releases surgical day units and theatre recovery, hopefully. And also then really, and when the new wards arrive in the start of the next calendar year. So that's the background. A surge, which the model I've shown here is only for illustration, but just happened to coincide with where we are now. But it was done about 6 weeks ago. That surge, if it was as big as the surge in March, April, would see us lose elective activity for a period of about 10 weeks. If it was half as big, it would see us lose activity for about 6 weeks. So our planning assumptions are based on those sort of modelling constructs, if you like, and that sort of impact of COVID on us in terms of where we are. It's worth pointing out that all our planning is very different from normal. You usually plan around escalation areas and escalation plans. Very difficult within COVID because the constraints that gives you. So I suppose the basic strategy, if you like, that we've devised is that we will continue to use CCU and CCU. It won't be closed because it's the right space now for cardiology. We will continue to deliver diagnostics throughout the winter, and we'll only take it down under very, very extreme pressure. So there will be no routine standing down of diagnostic capability. We will not stand down outpatients either, unless we have to release occasional members of staff to go and support inpatient care, and that would only be the peak of activity. So in terms of this winter's response is about continuing all of our ambulatory care in the same volumes as we're doing now, and not ceasing it unless there's a change in our expectation around COVID or external guidance that we should do so. We will continue doing elective care throughout the winter until such a point as we can't, and we'll stop at the point we safely need to, but we will restart as soon as we safely can. So elective care will continue through the majority of our winter. If we see a surge as big as we've seen previously, we'll have to stop for a period, but we won't wait for 1, 2, 4, 6, 8 weeks beyond that to restart that. So I suppose the other thing is that there are some really exciting pieces of work around SDEC that are happening. I alluded to them earlier on a little bit, that I think will bring us a very different sort of focus on the way we manage patients presented to ED, which includes direct access by paramedics, direct access by primary care, and by 111. And the Think 111 work will mature over the coming weeks and allow us to work very differently. So much as I talked earlier on about the Transformation Tuesday, there is a real sense of integration in the way that we're playing this winter. So the winter plan itself is a very different document. It's still not, it's its first iteration this winter, it won't be its last, and we'll do better in future years, but it's a staff-facing document for the first time ever, and it's meant to be more of a instruction manual. This is our approach to winter. So it both lays out our broad strategy, but also the details about what each provider is going to do and how we're going to work together. So I suppose they're the real key points, I think, that I wanted to make sure that the board understood.
Thank you very much, John. I mean, it is a great volume of transformational work that we've been able to put through, if you like, our operational side. But for me, the key thing to register is that despite all of the improvements we've made, all of the agility and flexibility we've designed into the way we do things, if the COVID situation becomes much worse than it is at the moment, we will find it very difficult to continue our elective activity for a period. We just all need to be conscious of that. Is that correct, John?
It is, Joe. There's an inevitability if that was to happen that we would. But what we won't do is have any artificial reduction of activity. So Absolutely. When pressure dictates and patient safety dictates and staff safety dictates, we will flex our work, but we won't do that in advance in preparation, or we won't hesitate to restart as soon as it's safe to do so.
Fantastic. Jane, is there anything you'd like to add?
I mean, I think it is a remarkable piece of work, actually, all of it. And John made that invitation to everyone earlier around coming to Transformation Tuesday, where a lot of this comes to life with the staff who are delivering it. So I think it's a good plan that we should be confident in, but we will be tossed on the seas of the things that are thrown at us.
Yeah, but I can't emphasize enough to members of the public who are watching either now or in the future this board meeting. The Wye Valley team are doing an extraordinary job to improve our efficiency and effectiveness as an organisation. Questions and perspectives, Richard?
Yeah, thanks, John. I mean, it looks a really thorough plan, so well done for that. Nationally, I'm picking up a lot of concern from local authority colleagues that the money that they had earlier in the pandemic to speed up hospital discharge isn't coming through, or it's not secure for the winter. And I'm just wondering, to what extent is that a risk locally?
Jane, do you want to answer that first?
Yeah, we don't feel it's a risk. There has been agreement around fully funding the discharge to assess pathways, and the local authority have recruited additional staff into Home First on the basis of that, and they've recruited them substantively with the view that we're going to have to keep this going.
Oh, that's really good to hear. Thank you.
And Glenn?
Yeah, I suppose the only risk around this is that we've moved to a fixed budget scenario rather than a system credit card approach, which is kind of what we had before. So there was just a retrospective top up where we've had to move to a fixed allocation. The accountant in me feels that that's necessary, but it could run out at some point. Yeah.
No, point well made. Thank you, Glenn. And we should always remember that our local authority colleagues, as Richard often reminds us, are not allowed to make a deficit ever. So they have our sympathy in the way they are funded. I can't see any other hands raised electronically or physically. So John, please keep us briefed on the winter plan. And thank you for all your hard work and your team's hard work. We're running a bit late now, guys, but we'll move on then to the Health, Safety and Wellbeing Annual Report. Erica?
Yes, very quickly, Chair. Last year's number of incidents, we saw a reduction of 130, which was very good. There are some incidents still happening, though, that are avoidable, and we continue to focus on sharps incidents, for example, which you'll recall we were subject to enforcement action, which was lifted. But there has been a downward trend in that, but there should be we should see a further reduction. The other thing to draw out is in last year we saw an increase in violence and aggression, and that prompted us to instigate the Op Nightingale, which we did just about 12 months ago. And a number of actions have started to be put in place in support of that to reduce the violence and aggression. We are and it's violence aggression from the public. We are continually monitoring that and to see what further measures we need to do to reduce those incidents further. But in general, the support for health and safety, I think we're seeing more engagement from staff, understanding that health and safety is everybody's responsibility. We're very well supported by the trade unions and their health and safety reps. And there is more of a focus about prevention rather than letting incidents happen. And getting health and safety on the front foot, which is good.
Thank you very much, Erica. Any questions on the Health, Safety and Wellbeing Annual Report? I just make the point for members of the public, it is always and totally unacceptable for any perceived or real acts of violence or intimidation against any members of our staff. Our staff do not come to work to be abused or to be physically or emotionally threatened. They come to work to look after members of the public. So please treat them with the respect that their work and roles deserve. Thank you, Erica. We therefore move on to the committee summary reports. The first is the Quality Committee of the 24th of September. Chris, anything you'd like to put out or add?
No, it takes as read, Chair, but just to note going forward, Lucy and I had a discussion because of the current operational pressures. There will be slimmed down agendas going forward and papers, but that does not mean to say that we will lose sight of any key matters, and we will continue to provide assurance to the board on these matters, but there will be papers.
Thank you, Chris. Any questions or perspectives to Chris on the meeting of the 24th of September? Please come off mute if there are. And then I think we've got the minutes from the 27th of August. Anything you want to add, Chris?
No, Chair.
Thank you. And any questions on the minutes of the 27th of August? Okie dokie. So I think we're then on to any other business. Please come off mute if you have any other business. And we've been informed of no questions from members of the public. So I would encourage members of the public, if you do have a question, please either email myself, Erica or Val Jones at the Trust, and it would be our pleasure to address your questions. The only final point I would make is that, and it goes back to some of the things we were talking about earlier, your NHS is open for business. If you have any health conditions that cause you an anxiety, please reach out to your GP or 111. 150 people a day die from prostate cancer, which is an avoidable cancer. That's not dying with prostate cancer, but it's dying from prostate cancer. So I would encourage, just with that one example, that if you've got any anxieties about your health or well-being, the NHS is there to serve you. Please reach out via 111 and we will do our utmost to ensure you live long, happy and healthy lives. Thank you very much, everyone.
Russell,
Look forward to seeing you.
Please, Russell.
Sorry, Frank.
Yeah, I did put my hand up. Sorry, just very quickly, the Armed Forces Covenant is held in great esteem in Herefordshire. The trust engaged with it a couple of 3 years ago. Erica was invited to the annual review breakfast the other day as a guest speaker. And I think the work we've done at Wye Valley should be commended, as should her work. We've done a great job and we're held in great regard for that. Thanks.
Okay, great. Thank you, Erica. And thank you, Frank. So we look forward to seeing you on the 3rd of December. Normally at that board meeting, we serve mince pies to members of the public, but unfortunately this year it's going to be a digital meeting again. But hopefully members of the public and members of the board will each have a mince pie with them to enjoy at the next public board. I look forward to seeing you on the 3rd of December.